Okay, we talk about overall imaging. We want to understand that there's a lot of angles to know, and in general, we may not actually be asked to state what the degrees are. So a lot of these angles you should just recognize as they're increased or they're decreased or they're abnormal. The best way to do that is just, keep looking at x-rays as much as you can. That being said, I have up a question here that's from an old ABFAS practice exam that they had posted online. And some of the questions, which we used a style of this in PodSurge 1, were to list angles for bunions, and then you have to know which angles are abnormal to then pick the right procedures. And this is one way of doing it instead of giving you an actual image of just going off the angles. But I would say beyond the angles of the bunions for your board exams, people may ask you the numbers basically for academic purposes, or if you're on an externship, just to see if you know them. But beyond that, we usually just look at how are they compared to a normal image. So is it increased or decreased? I'd rather you know something is abnormal by just saying it's increased or decreased and just forget the actual numeric value, because you at least understand the concept. All right, that was a little disclaimer at the beginning here. So when we look at overall alignment, we're going to come through some pathologies, but it's very important to understand that this is the same. So if you look at the Chrisman textbook on radiology, they show this image of 2 feet. This is the same foot, but on the left it's weight bearing, on the right the tube head axis is off, and it's not a good angle. If you have a non-weight bearing foot, you can't use angles for that. So it has to be truly weight bearing, where you're seeing the tibia perpendicular to the ground. It's usually 90 degrees. Sometimes people have a little bit of recurvatum, and it may be a little bit of bowing, but it needs to be loaded in order to be able to evaluate angles. If it's a non-weight bearing image, you can't tell the angles. Additionally, same concept, an image from Chrisman where they actually took the same foot, and the foot is in the center, and B is normal position. On A, they had the patient supinate their foot a little bit and get the sesamoids underneath that met head. And in C, they had the patient pronate their foot. So you can see the differences when you have a pronated foot. You're going to have the tarsal joint. Is going to be bigger, and the sesamoids are going to look like they're more in the inner space, where on the supinated foot, everything's going to tighten up as the foot's more superimposed on itself. Let's learn here that read the images that you have and go with the angles of what you have. But when we're actually taking them, you have to fully understand that sometimes our patients aren't fully weight bearing, or they're not in a good position, and that may not give us the best radiographic angles. On the AP view, so we're going to go through a few different views here, but on the AP view, we talked about talar head covering and Kite's angle posteriorly there, and we'll go through some more on the image in a bit. The navicular shape can look a little bit more supple and fully rounded, and crescent shape on a supinated foot, and on the right and the pronated foot, it may look like a little bit more of a wedge there. And the calcaneus we're going to show a little bit later here. So when we get a chance and we look at a Flatfoot x-ray, there are a bunch of images and a bunch of angles to go through. But we talk about the simaline, the sinus tarsi. So simaline, I'll do some drawings here. Oh, let me get back. The simaline, usually anteriorly broken on a pes planus foot type. The sinus tarsi, we don't have the visibility. On this foot, you may see that bullet hole sinus tarsi, it's more visible. A talar dome, when we look up here, is more curved for a pronated foot, it'll be more flattened for a supinated foot. Calcaneation is going to be lower for a pronated foot. And we can't really see the visibility of the cuboid, and we have all this metatarsal stacking and overlap. Let me see if I can mute. Can I mute everyone? Please mute your mic. Oh, here, I'm going to mute all. You're allowed to unmute yourself, so that way, if you want to chat, you can. All right, so we have an example of a flat foot here, right? So anybody want to take a chance at reading this one and talk about the angles that are wrong? Remember, you have to unmute yourself since I just muted everybody.
You have a weight-bearing right AP view,
Good.
an increased hallux abductor-algus angle with a possible increased pasa, the deteriorated joint space noted at the first MPJ.
Okay.
No osseous deformation, cystic changes noted in the proximal aspect of the hallux. Intermetatarsal angle is increased as well.
Good. Now focus proximal to this line. What do we have that's abnormal?
Are we looking at like the 2 to 5 angle, or are we looking at
Well, I'll draw some for you. Tell me what. So what's this right here?
cuboid abduction angle?
Sure. What should that normally be?
0 to 5.
Good. And then when we see the talus out this way and your calcaneus going this way, what angle is that?
Calcaneal angle.
Okay. Is this enlarged or is it normal?
Very enlarged.
Yeah, it is. So the normal angle we talk about is anywhere from like 16 to 20 degrees.
Yeah.
Some sources will say 17, 21-ish, but really we know less than 16 is more of a cavus type, and anything over 20, 21-ish is going to be more of a pronated foot, but you can clearly see it's significant. With the line drawn through the talus, what else do we have that's abnormal?
Talar articulation.
Good. So we see all of that. That's talar head uncovering. And the easiest way to look at talar head uncovering is to bisect the talus like we did here and to say, okay, that goes through about 50% of the talus. So we have about 50% uncovering here. Normal should be about 25%, 30%, but we have significant talar head uncovering there. What angle can we look at with the talus in the first metatarsal? A lot of these, you can just put the two bone names together. So you can have an AP talar first metatarsal angle, and that should be, those should be ideally parallel. If we go back to the rectus foot type here, when you draw out the talus, you know, it's getting pretty close to the down the middle of the first met. It's very rare that that's perfect, but it should be close to it. Okay. Anybody want to read the lateral image on this flat foot?
One lateral view of the right foot.
Good.
Going to be decreased calcaneal inclination,
Good.
decreased talar declination. No, increased talar declination.
Right. That's always tricky, right? Because the talar declination we're measuring like that.
Correct.
And the calc inclination is basically pointing straight down. So it's not the normal close to 20 degrees dorsiflex that we see. What other angles are off here?
It's a little blurry in the midfoot, but if we go to the forefoot, you can see, I think that's Mary's.
Yeah, so is Miri's negative, positive?
Right now it's negative.
Good. So if it's pointing down, talus is pointing down, we're getting a negative Miri's. If the talus is pointing up, we have a positive Miri's. If you can't remember Miri's angle that way, you can do what you did first, and you can say there's increased talar declination angle. Or you can just say something as simple as there's a plantar flex talus. So if you blank out, especially on an interview, if you can't remember MIRIs, because sometimes we forget those things, just describe what you see. You're not going to be wrong if you describe it. It's just like a math problem where you get credit for your work along the way, but you just might not get the answer. Something else we look at on a lateral view is we may talk about something like the fault, the break, sag along the medial column. Anybody have any idea where we would say that there's a fault or a sag at this one? Or how we evaluate that?
Navicular drop.
So I see a lot of people saying TN in there. What we do is this first line here is bisecting the first metatarsal, and then it goes through the middle. You can see the cuneiform right here. Does it look like it's going through the middle of the cuneiform? Yeah, it's pretty close. And then we see the navicular right here. It looks like it's pretty close to the bisection of the navicular. But then when you look at the talar head down here, and we bisect that, really go on like that, we know that we have the lines from the talus plantar to the area of the bisection of the navicular here. So we would say that this is a TN sag, a TN fault, a TN break, etc. So if you're given the option of doing a procedure on an externship or interview, and they say, all right, because we know there's a lot of procedures to do for a flat foot, and you said, I want to do a TN fusion, if you can back that up by saying, because I see that's where the fault is, the break is, in theory, if you elevate the talar head and then we fuse across these two, then it should realign everything so it's one continuous line. So that helps us determine which joints we would want to fuse depending on where the fault, the sag, the break, etc. is. Anybody want to read this one and tell me what stage flat-foot it is?
I can go ahead and try. Looks like the ankle is in slight valgus. There's like some slight arthritic changes in the ankle joint, which would make me think this is probably like a later stage, possibly 3 or 4.
So you are correct in that regard, but what's the classification for a flat foot?
It was Johnson Strom.
Right, and with the Meyerson addition, so we talk about stage 4 is specifically what?
That's when you start getting more ankle and deltoid issues.
Correct. So you have ankle valgus here, just like you said, and you can see the talus is really abutting, and you get maybe some of the calcaneus coming up down here. So this person might have subfibular impingement, but they definitely have a valgus ankle. So if you saw this alone, you could say that it's flat foot PTD stage 4.
Okay.
Good. All right, when we look at a calcaxial view, we can look at a couple things. So one, we want to look at how's the width of the calcaneus. We don't really see any irregularities on the cortex. We don't really see any increase in width. We're not worried about a fracture. And we look at the overall intrinsic calcaneus. The line's a little bit off there, but it's a pretty straight bone. We don't have a lot of curvature to it. Sometimes with a varus foot, you may get a little bowing to it. And what kind of procedure can we take a lateral wedge out to get that bowing closed down so that way when we close it, we make a straight line? What's that one called? Good, a Dwyer. So a Dwyer is when we take that wedge out. So we don't see any sort of bowing the calcaneus. It looks pretty straight. So any sort of deformity we have is probably going to be extrinsic to the calcaneus. If we look above it, we can trace out the fibula here. And we see the talus kind of coming up here. And here's your medial mal. So if we're going to bisect the talus, it's going to come up like this. And the tibia is kind of up like that. So where do we think our deformity is at this point? I like that on the side comment. Dwyer wedge out, Evans wedge in. That's what you're here for, Dr. Clarity. All right, what do we think We kind of have the answer to this one because there's a post-op image on the right, but when you bisect the talus and you bisect the calcaneus and they don't align that way, we don't have an intrinsic calcaneal deformity. We have a deformity at what joint is this? Good, we got a lot of STJ people, good. So in that case, we can bring the calcaneus over, prop up the talus to get back on top here. And then now you can see if we bisect the tibia, the talus, and the calcaneus, besides my shaky hand, it all comes in one line right there. So we bring that back over. So these are things to look at when you're evaluating a subtalar joint on a calcaxial. All right, who wants to cover abnormal angles on a pes cavus foot?
I can try this one.
Okay. So what do you see that would, when you start describing, you know, is pes cavus?
I'm gonna start like posterior, so with the calc inclination, it's
But
increased,
we don't have too much of it, but you're correct. That's what we would see.
and then decreased talar declination.
Okay, it's gonna be more flattened, right?
Right.
Good.
And then Mary's angle right there would be positive.
Yeah. So let me redraw this here. So when we look at the bisecting the talar head, we may get something like this in the first met. So it's going to kind of interact up here as opposed to the Flatfoot was kind of down here. Good.
And then with pes cavus, you see stacking of the metatarsals. You see the cuboid and
Good.
fibula is posterior.
Good. And then you can see here we have that flat talar dome too.
Right.
And what do we call this?
Oh, the blood hole sinus tarsi.
Good. And then
And a posterior simuline.
yeah, think about how hard. Wow, that was a bad line. I'm drawing is off today. Think about how hard it is to get a talus that sits really posterior to the calcaneus. So even if it's not posteriorly broken, it may be pretty much symmetrical, whereas in a flat foot, it's always going to be anteriorly broken. Good. You kind of covered all of that. So how would you describe this calcaxial, and what type of foot is this one?
So this would be calcaxial inverted. So I'd say it's a pes cavus foot as well.
Yeah, and you can see
Ankle
that
there's
joint posterior facet is there. So it bisects like that. So this one doesn't have a lot of varus to it. So what procedure could you do to help straighten this one out? You already saw this.
the Evans, no, the Dwyer, put it in.
Or a subtalar fusion.
Oh, the fusion, yeah.
Yeah, we don't see a lot of bowing, then a Dwyer works better.
Right.
But you can fully evaluate too. I mean, if you're somebody who has a painful subtalar joint, then it should be a slam dunk with that. But if you have somebody who has no pain on their subtalar joint, maybe you want to do a little bit of a Dwyer and just slide the calcaneus laterally. Okay, when we look at an AP view of the foot, some things that aren't necessarily angles, but they're overall general alignment things, is we look at what's abnormal here for this Liz Frank injury on the right.
Just increase clear space between the medial cuneiform and base of the second met. Or it's not aligned. Oh, on the right AP view, it's shifted.
Good. You can
laterally
step off here, right? So
right.
You look at the second met base, middle cuneiform, and then if you had an oblique, we would look at the fourth met base and cuboid. So those are important things to identify. Anybody want to go through all the angles of a bunion?
I can try, Dr. Azante.
Okay. What I will do is I'm going to start drawing them and you tell me what they are.
Okay.
So this one is pretty straight, but what do we call that angle there between these two bones?
Would that be okay? So I have two in mind. Could
Sure.
it be hallux interphalangeus angle, or would that be DAF?
Nope, this is hallux interphalangeal angle, or HIPA.
Okay.
And that one should be sort of 10-ish. It's pretty hard to get that abnormal, but it can happen. What do we call it if there's an intrinsic deformity in the proximal phalanx where you have some kind of bend to it that way?
You have some kind of bend to it that way.
Yeah. Where you might do an Aiken to correct for the abnormal angle.
DASA,
Good. And what should that be?
0 to 8.
Good. So if you have an HIPA that's abnormal, what procedure can we do to fix that one? This is a tricky one because there's nothing. If you had a very straight proximal phalanx and then you had an abduction at the joint level, you don't need to do anything to the proximal phalanx, but what do you need to do to the joint?
Fuse the joint?
Fuse it. Good. So that would be your procedure for a HIPA that's abnormal. A DASA, you said you can do an Aiken.
Right.
As we move proximal, what angles do we have?
Then you'll have your hallux abductus angle.
Good. And what's that?
That should be 0 to 14 or 15.
Yeah, about 15. That one's almost always increased because we have your abductor hallucis pulling on that, and you have that retrograde buckling from the hallux down. So that one's almost always. What do we do in theory to correct that one?
You could do. Can you do a proximal, or sorry, a distal metatarsal osteotomy, something towards the distal aspect of the metatarsal to fix it?
Well, we do. This one is where you're going to want to release the abductor hallucis through your lateral release.
Okay.
Fusion could fix that too. When we start to talk about doing distal osteotomies, those are relative reduction in IM angle there because you're just shifting a bone over.
Okay.
So what do we have to get to in angles? We said about 15 degrees there. What angle is out this way?
Pasta,
Yeah, and what should that be?
0 to 8.
Good. And what procedure corrects for an abnormal PASA?
Could you do like a Reverden green?
Good. You should do a Reverden green layered. Reverden green is just going to protect the sesamoids and close down the wedge. And what does a Reverden green layered do?
I'm pretty sure you gave this lecture.
It's okay. So a Reverend green layered breaks this lateral cortex. Think of the L as lateral cortex, so that way you can shift this over.
Yeah.
So a Reverend green itself will correct for an abnormal PASA, but a Reverend green layered will correct for PASA as well as an IM angle correction.
Right. Okay.
And then what's tibial sesamoid position here?
Yeah. Would that be a? Let me see. 5?
Yeah, I see some 5 to 6. Again, my preference, if you get 5 or 6, that's fine. If you said this is a 4 or a 7, not as much. What we like to think of is if you look at the sesamoid, and if the sesamoid is right down the middle, when you bisect the first metatarsal, that's a 4.
Mm-hmm.
And then a 5 should have some sort of overlap, and a 6 would probably be just touching, and a 7 would have some gap there. Just like if you go the opposite way, 3 should have some overlap, 2 kind of touching, 1 would be some gap. So just remember 4 is right down the middle of it. And then next, we can get into the first and second IM angle.
Right.
What is that normal?
0 to 8.
Okay.
Did you ask another question? Sorry, if you did, I didn't hear it.
Sorry, what's the first and second IM angle?
0 to 8.
Yeah, with this one, it's when you read different resources, they say 0 to 8. Some people say 0 to 12 because 9 could be normal. You know, it's odd when people talk about angles like in Kite's angle 2, where we say normal is this, but it's not abnormal until it gets up to a few degrees higher where there's like a little buffer zone.
Right.
So you can read anywhere sources from 0 to 8 up to 0 to 12. We talk about over 12 being pathologic, but at the same time, if somebody has an IM angle of 8 and they have a painful bunion, then we know that we may do Lapidus, because it's an insufficient first ray that may be leading to that. So it's more of a clinical evaluation combined with x-rays. But we think smaller, we're going to go distal. Larger IM angles, we're going to go more proximal. But again, that can be antiquated as far as how we think of it, because you're going to meet some people who just do a Lapidus for everybody, because we know that you get a good correction there and you get some stability the first ray.
Okay.
What do we look at when we come with this right here?
Met protrusion distance?
Yeah, what should that be?
1 to 2.
Good. So plus or minus 2 millimeters.
Yeah, plus or minus 2.
So this would be the first met is shorter than the second. Good.
Right. So shouldn't it be equal to the third?
It can be, but it just depends. Really, we're only measuring met protrusion off of 1 and 2.
Okay.
There's like a whole 4-foot angle you can look at like this, but I don't really think it's useful. At least in my opinion.
Oh.
Here's an example we looked at earlier. I just want to show one of a DASA that's abnormal, where you would come like this and you see the intrinsic deformity of that phalanx. All right, to go a little bit more proximal, this one was actually taken from a PI update article from my old roommate is out. He was at the Scripps program in San Diego with Don Green. So they published an article on looking at 2 different angles in the midfoot. Does anybody know what angles we're looking at here?
It's a metaductus.
Good, metaductus angle. And then something over here is a different type of angle.
Is that the Kilmartin? No, it's not the Kilmartin angle. Well, it's still the metaductus angle. You're just measuring it in a different.
It's another way of measuring it. Yeah, I see a bunch of people in the chat room saying angles angle, which is what the answer I was looking for is. And the reason why people like to look at, well, at least they propose the idea of looking at angles angle is because you have a lot less measurements. And they talk about in their article, if you're measuring your metaductus angle with different points, you can actually get a different measurement for it. So they're proposing if you use angles angle and just do the cuneiform bisected with the second metatarsal, an easier way of measuring. But you're looking at something, a metaductus angle is normally 15 degrees or less. And how do we factor that into our bunion procedure selection? If you have, let's say, a metaductus angle of 17 and an IM angle of 12, anybody remember? I think this was in Dr. Pratt's class.
So it's the metatarsus adductus angle plus the intermetatarsal angle minus 15.
Good. So that can help with procedure selection. We just need to factor that in. And if we're doing a Lapidus, you just have to remember, if you have a really adducted second, maybe it looks something like this, you're not going to have as much room potentially to get that first ray over before it really abuts up to it. So you just have to factor that in your pre-surgical planning.
Just out of interest, do you address the metatarsus adductus or? Not
routinely, unless it's going to prohibit the first metatarsal from getting where we want it to be. But usually I stay away from it. I know some people like to address it all the time. That's just my preference, though.
Okay.
All right, we have a pathology at the posterior calcaneus. I know some of the students last week I was talking about in clinic. What are the 2 angles we look at when we want to evaluate a Haglund's deformity?
So bursal projection, which is actually more of a measurement, and the inclination angle of the calcaneus.
So we can look at basically when we're looking at the inclination of the calcaneus, I see some people in the chat room saying Fowler-Phillips angle. And this one should be like 75, 77 degrees. If you have more of an outward bowing here, we have too much bone back this way. And the other one could be a parallel pitch lines, where we kind of draw the line on the superior surface of the calcaneus and the inferior surface, and we draw this line. And if we have anything in this little area up here above it, then we call it a Haglund's deformity there. All right. Is there anybody here who was in clinic last week that was looking at this one that wants to talk through the calc fracture?
I can give it a go.
Oh, sorry. Somebody said we supposed to be clinic. No, we just have a small rotation.
Sorry, I can't hear you.
I was just answering a question. No, nobody's supposed to be in clinic. We just have a rotation in our private office right now. All right, go ahead. What did we talk about here?
So this was did you want me to go over the clinical portion as well?
No, you could just go over the imaging that we're looking for on calcaneal angles for a fracture.
Okay, so in this image, we're looking at a lateral foot and we see a joint depression type fracture.
Okay.
And the angles that we look at for a calcaneal fracture are Bowler's angle and the
Critical.
Starts with a C, right?
Critical
Critical angle?
of.
Jesus, I can never pronounce it properly.
Yes, I can't either. Just saying or just saying good.
Yeah.
So if we look at Bowler's angle, what happens to it on a calc fracture?
It decreases.
Correct. And then what do we talk about? Because for years of teaching students, even out in California, people have asked, because different resources say different things for the critical angle of Gissane. So how do we understand what we're actually looking at there?
Well, you mentioned that it can be a little controversial because it depends on the way that the posterior facet of the calcaneus kind of falls.
Good, because we're drawing the facet, right?
Right.
We know that when we're drawing our facets here, critical angle of Gissane should be about, contrary to Bowler's, which is like 28 to 40, critical angle of Gissane should be like 120, 140. And it really does depend, because if you get a joint depression fracture fragment where the posterior facet sits like this and just tips down more posteriorly and flattens out, it's going to give you a much different angle than if you have a posterior facet where the front tips down and it's pointing more inferior. So you just have to understand that this is a little bit more of an older way of evaluating calc fractures, because what do we order now?
Sorry, what do we order now?
CT.
Everybody in there is saying CT scan. Good. So it's a way, if you look at people who are going to publish articles looking at reduction of calc fractures and something more academic, they may use Bowler's angle and critical angle of Gissane as far as outcome measurements, but on a just routine basis of a calc fracture, we're going to get the CT scan, which is going to show us the best image of it. But I just want everyone to know, like, when you actually look at it, you'll see different resources that talk about angle of Gissane being increased or decreased. Don't get confused by that. Just understand that it really does depend on how the posterior facet tips, because it can tip in different ways. All right, do you want to go over what we see abnormally on the calcaxial here, Suki?
Sure. It's kind of tough to see on here, but what we saw was 2 fracture lines, and we classified this as a Sanders 3AB.
And what structural deformities do we look at that are abnormal on a calc fracture? There's 3 we should remember.
A widened calcaneus.
Good. You see some of the lateral wall blowout there. Good.
The length of the calcaneus, like the height.
Okay, and what does this represent over here? Well,
that there was, it's like a buckling.
Yeah, so what fragment is this one right here? What do we call that?
The most stable fragment.
Good, because it is
attached to the deltoid, and it's the substentaculum tali fragment.
Good. So we can see the tuber of the calcaneus is buckling on it here, so we're getting some shortening that way, just like we see with fibular fractures. And then what's the overall
varus
alignment? Good, varus position, good. All right, we're gonna get into, we just have a few more here before we let Nikki take over. When we get into looking at ankle fractures and syndesmotic injuries, we've covered this one before, but what do we call between A and B? What do we call that? Tibfib. Clear space.
Overlap? Oh, sorry.
No, that's okay. That's why we're going over this. The clear space is the more radiolucent area between the two bones, and the overlap is the more radiopaque area, where if you look up here is the anterior tibia overlapping the fibula. So overlap, again, resources may be different, but in general, overlap. Some go as low as saying at least 6 millimeters of overlap. And then clear space is the opposite. We don't want a lot of it, we want a little of it. So if we have more than 5 or 6 millimeters of clear space, then that means we have what type of injury?
Diastasis.
Sorry, I see my mic keeps cutting out. I'm almost done here and Nikki takes over. I apologize for that.
Can you repeat the question you said, because I didn't hear it?
If you have increased tibfib clear space or decreased overlap, then we have diastasis of the syndesmosis and a syndesmotic injury. And this one is 13 millimeters in the medial gutter. What's the normal cutoff for gutter clear space? Good. I see 4 millimeters in the chat room. With this being said as well, there is a cadaveric study, or I don't know if it's cadaveric study, but there was a study looking at people with normal deltoids versus abnormal deltoids and got contralateral imaging. And 4 millimeters is the cutoff we should go with. But if you're really not sure, you're really concerned, you can actually have up to 7 millimeters be normal. So if you have any widening, you just want to actually palpate on the deltoid and stress it to help with your clinical diagnosis. Something else we look at is with the externally rotated fibula, you may see widening of the fibular fossa there. So you see more radiolucency distally. Sometimes we have patients who have had previous injuries or they have ankles that are healed in an abnormal position. How would we, or what's abnormal about the way that this person's fracture healed? Short fibula. Good. So there's 2 different ways to evaluate the short fibula. One is the talocrural angle, which should be about 82 plus or minus 3 degrees. That one does not take into effect what happens at the distal tibia though. So if you think you have maybe something abnormal with the distal tibia, we can look at the plafond malleolar angle, which should be about 9 degrees. I have a better drawing for you guys here to see this. So this is out of Gerard Paley and Bradley Lamb's article. When you're looking distally, if you're concerned that there might be some distal tibia pathology, maybe from a pilon fracture, then a plafond malleolar angle can tell you that the ankle joint is well aligned, whereas you could have a very abnormal talocrural angle, but it doesn't take into account the actual articulation of the ankle joint. Additionally, we see the anterior distal tibial angle here on the side view. And we want to keep that in mind because if you're doing ankle fusions, we talked about getting the lateral talar process underneath the tibia bisection. If you're doing ankle replacements, you want to make sure that your components are pretty close to this line. If you put your components angled where you're too dorsiflexed, tibia may slide off the back of the talus. And if you put your components in where you're too plantar flexed, you may have just jamming anteriorly, and we get that osseous equinus. Here's just an example that I found from one of our cases in residency, where you see this distal tibia that is actually rotated in itself. So you would get better use of your plafond malleolar angle, although you can't really tell where their ankle joint is. It's going to be more parallel like that. So this one would require supramalleolar osteotomy to straighten it out rather than at the actual ankle joint. I have 2 more to go and then we'll get to Nicole. This one is a hindfoot alignment view. When we're talking about maybe flatfoot or deformity correction distally, if we bisect the tibia and we bisect the calcaneus, you should have less than a 1 centimeter gap between those 2 lines there. If it's less than a centimeter off, we're okay. If it's greater than 1 centimeter, then you might want to do your medial displacement calcaneal osteotomy to bring it back under alignment. As in this place here, where we kind of realigned the calcaneus more medially. And then lastly, if you're worried about somebody who's got a limb length discrepancy, you can get these scanogram images, which is basically 3 separate images where the radiologist puts this big radio opaque ruler underneath the patient and measures from their hips, their knees, and their legs. So you can actually identify where the deformity is. We can see their ankle joint on their right is around 86 and on their left is around 84. So you'd want to keep going up the line, and you can say, all right, are their kneecaps, are their patellas at the same level? Are their hips at the same level? For this patient, she actually had a hip fracture, so we went all the way up, and the deformity is all the way up at her hip. But this can allow you to plan distally too if you need to get those. Okay, Nicole, are you ready?
Yeah.
Can you share your screen?
Yes. Let me figure that out real quick.
Okay.
It says I can't share until the other participants stop sharing.
I can fix that. There we go. Stop sharing.
Okay. Can everyone see this?
I can see it.
Okay. Okay, so I read the McGlamry chapter on ankle replacements. So whenever you have to do ankle replacement, you need to think that the ankle is one of the determinants of gait and that you want to maintain dynamic limb length. Most of the ankle movement occurs in the sagittal plane. And then just kind of like the gait cycle, just think of when you're walking and what the ankle is functioning to do, if it's plantar flexing, dorsiflexing, and its main function. So whenever you have to evaluate a patient, you want to know that the ankle and subtalar joint, they are working together in all 3 planes, and the normal loads cross the ankle joint. So during heel strike, it's 3 times your normal body weight, and then 5 times your body weight during mid stance. And the book didn't talk about this that much, but I remember reading articles that like you have to think about when working out or like running, that's going to increase the normal compressive loads. The tibial metaphyseal bone strength is greatest at the subchondral bone level, and it gets weaker as you go away, so you have to keep that in mind. And then you always want to look at the CFL and the tibial calcaneal ligament whenever you want to do a fusion or replacement and see how they're functioning. Most approaches, you're going to do an anterior approach. And when you do an anterior approach, you just have to look out for the tibialis anterior and dorsalis pedis arteries. So why are you going to do an ankle replacement? You want to achieve a durable and functional ankle that will allow the patient to return to normal activities of daily living. Versus an ankle arthrodesis, some reasons you don't want to do that is you can get malunion, pseudoarthrosis, and many studies have shown decreased stride length, gait velocity, and canthus. So indications: severe end-stage osteoarthritis, inflammatory arthritis, post-traumatic arthritis. And the patient needs to have good bone stock, good normal vascular status, hindfoot alignment is huge, and lower physical demands. Contraindications: obesity, younger age, which it's debatable among many doctors, avascular necrosis. You will not do it though if the patient has severe malalignment or if they have like Charcot infection, severe soft tissue issues. So hindfoot and leg malalignment. Malalignments can impinge and contract during normal gait cycle and affect the ligaments surrounding it. So whenever you are doing a replacement, you have to make sure the foot is balanced. And always remember, if you have to leave the foot, you can't leave it perfectly rectus, leave it in slight valgus, thou shalt never varus. Always remember that. So the procedure, you basically are gonna have the patient on the operating table in the supine position. You're gonna put a tourniquet on. You're gonna place your incision between the tibialis anterior and the extensor hallucis longus tendons. When you do this, look out for the medial branch of the superficial peroneal nerve, along with the dorsalis pedis and tibialis anterior artery. When you insert your prosthetic, you always want it to be slightly larger so it can better disperse the weight-bearing loads. And when you do your bone cut, you want to be center to minimize cutting into the posterior tissue, and you want to remove all bone that's there You're going to insert your implant, check it via intra-op radiographs, and then do a layered closure to the ankle once you're done. So other procedures when you do an ankle replacement, you might have to do hardware removal, equinus release, a calcaneal slide, ligament reconstruction, or a supramalleolar osteotomy. Remember, you always want to keep the ankle in balance with these procedures. Postop care, you're going to have them non-weight bearing for 6 weeks. That's what the book said, although some surgeons will vary. And then you're going to put them in a posterior splint. VT prophylaxis, even though it's considered low, you still want to like keep this in mind and know that each patient is different. And then you're going to do x-rays every 3 to 4 weeks. So there's many designs for the TARs, but the basic components, you have your tibial tray, your trochlear, and then you've got this like in-between layer of ultra high molecular weight polyethylene. So these are like the two, that's a 2-part and that's a 3-part design. So the 2-part designs, you've got the agility LP total ankle. The big thing about this is that you do have to fuse the syndesmosis, which is not always ideal. You have to do more bone resection. You can have the end bone, which is good for frontal transverse plane stability, but you have to do a larger resection of bone. So the agility I have listed on the left and the end bone is on the right. Then the Salter talaris and anatomic ankle. And this is nice because you kind of got this anatomic talus. It's going to provide more of a triplane motion and you have less strain on your ligaments. And they also talked about the ESKA ankle joint, but that one they said was very thick and you really don't see that too often anymore. So the Salto talaris, ESKA. And then there's a lot of 3-part designs, but the only ones available in the US is the STAR. And the tibial component has like these 2 barrel-shaped rails to help increase the surface area and to get better osseous fixation. And this is performed very well. There's less than 10% failure rate at like 5 to 10 years. The only issue is it's kind of hard to evaluate if you think that it's coming out of the joint. Complications, intra-op, you could have a fracture when inserting this. You can get malalignment. Post-op, it's kind of like the normal things you think about after you do surgery or fixation, infection, pain, thrombosis, and that's it.
Okay, very good. So just for your own edification and for everybody out there listening, that was a pretty short one. That was about like 6 minutes. When you get out on externships, whenever that is allowed finally, you want to keep them to about 10 to 15 minutes. So nice and concise. You did even mention in there too that you said about the non-weight bearing portion for 6 weeks, although some people are doing differently. It's good to acknowledge with total ankles that this McGlamry book chapter was published a few years ago, right? So even since then, the right in bone is more of a revision implant. Right has moved on to their CT guided, their prophecies, and their infinity implants, which are quicker to put in and remove less bone. So it's important to continuously stay up on the technology of putting an implant along with the post-op course, because people are starting to weight bear them earlier, so we get less adhesions. What do you think is the biggest problem with weight bearing somebody too early with a total ankle?
I would be afraid that it maybe, if it's not completely fixated into the bone yet, that it would maybe like come out and you get like osseous deformity.
What about something even before that? You mentioned your incision for these, right?
Yes.
So almost all of them, except for the one with the Zimmer with the lateral approach, is going through the anterior ankle.
Mm-hmm.
We can just a little bit of motion there can make it very difficult to heal an incision over the anterior ankle.
Oh, right, because you don't have the same muscular and vascular supply at the anterior ankle.
Good. Yeah, there's a lot less tissue, and just even think about like less tissue than if you get a knee replacement or a hip replacement. So we just want to make sure everything is really coacting well with that incision before we start to get them to put some weight on it. But with that being said, we're getting better and better as a profession at these procedures. So when you're on an externship, just read up on some newer articles because we're pushing the envelope a little bit more. All right. questions on anything?